So welcome everybody to this 2023-2024 Anne Klibanski Visiting Lecture Series. My name is Anne Levy. I am the Senior Program Manager for the Center for Faculty Development. In today's session, we have the honor of having Dr. Anthea Lindquist here at 2 a.m. her time from the University of Melbourne in Australia to present on big data, causal methods, and clinical conundrums, one of my favorite words, using observational data to emulate target trials and answer difficult questions in obstetric practice. Before she begins, I will race through a few announcements. It's a very brief history of the Anne Klibanski Visiting Scholar Award program, which was created by our former Center for Faculty Development Director, Miriam Bradella, to offer Mass General Hospital women faculty the opportunity to serve as virtual visiting professors and give grand rounds or other special lectures at national or international institutions. These opportunities organized by the Anne Klibanski Scholars champion, a senior faculty member at Mass General, with the coordination of the Center for Faculty Development. Next slide. This program and the accompanying lecture series, which you are attending today, is named after Anne Klibanski, the current president and CEO of Mass General Brigham and former director of the Center for Faculty Development. A highly successful researcher, Dr. Klibanski has been a strong supporter and advocate for women over the years. Next slide. We have had so far 4 cohorts of Anne Klibanski Visiting Scholars, and this slide shows the inaugural cohort 2020-2021, 36 scholars worth. The second cohort in 2021-22 had 32 scholars. The subsequent cohort in 2022-23 had 31 scholars. And our fourth year, our current scholars add up to a total of 29 women faculty. Next slide. The program, as I've already pointed out, would not be successful without the commitment and energy of those we call our Anne Klibanski Scholar champions, the senior faculty who help the scholars find exciting speaking engagements. Dr. Jan Schifrin, highlighted on this slide, is going to introduce today's speaker, and the institution from which the speaker comes, University of Melbourne, Australia, hosted one of the current Anne Klibanski scholars that Dr. Schifrin championed, Dr. Milena Weinstein. The goal of this lecture series, which grew out of the Anne Klibanski Scholar Program, is to catalyze and foster collaborations across national and international institutions. And on the next slide, you will see some of the institutions we've collaborated with over the past 4 years. And highlighted in yellow, for obvious reasons, is the University of Melbourne, Australia logo representing Dr. Lindquist. Now I will pass the microphone to Dr. Schifrin to introduce today's speaker.
Thanks so much, Anne. And again, it is thanks so much, actually, to Anne and Brenda for the amazing amount of work they do, both to orchestrate this lecture series, which has been extraordinary, and of course, to organize the Anne Klibanski Scholars and their international partners. You know, it just is just a wonderful way for both the scholars abroad and the scholars at home to make international connections, to boost their CVs. And so just thanks so much. I know how much work goes into the program from your end. So it's an absolute pleasure today to introduce our Anne Klibanski lecturer. Dr. Anthea Lindquist is an obstetrician gynecologist and perinatal epidemiologist. She practices clinically at the Mercy Hospital for Women, a major tertiary referral center in Melbourne, Australia. And she's also the co-lead of the perinatal epidemiology group at the University of Melbourne. And I should say we've had a wonderful connection with the university. Several of our Klibanski scholars have spoken there and vice versa, and every lecture has been terrific. Thank you. It's a great connection. Her research examines the long-term impacts for mother and baby following different exposures during pregnancy and the periconceptual period. Together with her team, Dr. Lindquist has been the first to publish research in the field of obstetrics using statewide data and causal interference methods, whereby big data and a causal analysis framework are used to mimic the conditions of a randomized trial. This approach has allowed Dr. Lindquist and her team to examine research questions that would not be feasible or ethical to study in randomized trials, such as the long-term school-age impacts of for children of IVF versus spontaneous conception. And just this is actually, we have many of our REI fellows and faculty on the call today and really interested in that question and other related ones. So Dr. Lindquist and her team are commencing the next phase of big data studies, looking at exposures to common but understudied medications during pregnancy. So again, Anthea, thank you so much for joining us and really looking forward to your presentation today.
Beautiful. Thank you. And thank you, Jan, for the introduction. I'm so delighted to be here. As discussed, we do have a very unique connection with this lecture series, and it was a real thrill to be invited to present today, tonight, this morning. I'm not entirely sure. It's the dead of night here, but I'm still very happy to be online with everybody today. So as mentioned, I am a clinician and perinatal epidemiologist, and today I'll be speaking to you about our work using big observational data sets and certainly trying to look at clinical questions. Brenda, am I going to be able to advance the screen at all? I am funded by a National Health and Medical Research Council Emerging Leader Fellowship in Australia, but I have no other declarations. So I thought it was worth just starting with a little bit of a look at our team. My team, the perinatal epidemiology group at the University of Melbourne, is co-led by myself and Roxanne Hastie, who's that very friendly face on the far left. We're both early career researchers, and we wouldn't be able to lead a team like this without the support of more senior researchers. So Professor Stephen Tong and Professor Sue Walker help guide our team and certainly our projects. And as you can see, we've got a really terrific and expanding group of people under our leadership. We've got a number of students and staff. We've got clinicians across sort of different disciplines of obstetrics, but also IVF specialists, maternal fetal medicine, and 2 midwives working with us, which we think is really important to champion midwifery research, and an ever-rotating roster of medical students and residents keen to be involved in research. So one of the great things I think for us is that we bring a wealth of experience from different aspects of women's health to our research, and it means that our research focus is fairly varied. So within our team, we've got a number of different research priorities. We are interested in looking at periconceptual exposures in pregnancy, the obstetric decision-making, especially those time points where there are 2 decisions that present and we just don't really understand the longer-term implications of both of those decisions. We're sort of keen to explore that using big data. We have done a number of projects so far looking at safety implications of exposures in pregnancy, so those short-term outcomes. Equally, we are interested in the long-term outcomes for the offspring following pregnancy exposures, and this is a really understudied area, sort of hard to believe in many ways how many decisions we make in obstetric practice where we don't really understand the long-term implications for the offspring. And that's an area that we're particularly interested in as a research group. The main emphasis, I guess, that we have is improving clinical practice and clinical decision-making for women that we look after. We're certainly interested in doing that in our own context, but equally hopeful that our research has application abroad and in low and middle income countries, but also in other similar jurisdictions around the world. I'm so sorry. I hope this is not too tedious for people, the changing of screens. So pregnancy is a time that is the first interaction that many women have with the healthcare system. They often haven't seen clinicians before on a regular basis, and they certainly haven't visited hospital a lot of the time. And as a result, they often have so many questions about their care and the impact of their pregnancy. So timing of birth is something that a lot of women ask about, how they're going to give birth and when. The safety of medications that they use in pregnancy, particularly prescribed medications. You know, we still don't have a great deal of data about those kinds of things. The impact of their lifestyle and health decisions during pregnancy on their offspring. And also the role of, or the impact of, complications of pregnancy that arise, certainly that they may not have had before, and the impact of those on their children. And sometimes, often, we're able to reassure patients about the impact of those things, but there are so often more questions than there are answers. And a lot of this gets back to maternal health outcomes and just wondering what the impact is for the offspring of these pregnancies. And this is where a lot of our work comes into play. So randomised trials are historically considered the gold standard, if you like, of clinical evidence, where a group of patients are studied, they are randomised to, you know, particular exposure. And because the characteristics between those groups are comparable, then any difference that's observed in the outcome of interest can be put down to the exposure or the intervention per se. But randomised trials are, despite being the gold standard of clinical evidence, if you like, are not without complications. So they're often really difficult to perform and to get over the line. They are expensive to run, and this has become even more evident since the COVID pandemic. They frequently require vast numbers of patients to be recruited, and a lot of the time this is because you know, they're looking at often rare outcomes, and in order to do that, certainly in a randomised fashion, you need a large number of patients. They often have, you know, significant limitations, especially time. So in the context of pregnancy, if you're wanting to look at longer term outcomes for the offspring, it can be many, many years of following up that cohort before you can have any answers about the pregnancy exposure. And in the context of pregnancy, the conduct and outcomes for randomised trials are often riddled with ethical issues. So, you know, is it ethical to randomise women to an intervention in pregnancy when we really don't understand the impact for either them or their offspring? And this is where causal inference comes into play. So just as a little bit of a backstory, I finished my PhD 10 years ago. I did it in the UK at Oxford, and we used logistic regression for many of our analyses with adjustment for relevant confounders. I then came home, finished clinical training, finished my specialist exams, had my first few babies. A long period of time passed, and then I was given a lifeline back into research in about 2017-18. And Roxanne and I acquired, you know, some very large data sets, and we met with a few senior biostatisticians who said, you know, I think you'll still be looking at these questions using logistic regression. And I thought that just cannot be right. Surely the field has, evolved in that time, especially when we're looking at really complex exposures in pregnancy. So we started to hunt around and look at the literature, and benefited greatly from an anaesthetist who works with us, who's also a biostatistical whiz. And he said, yeah, I think there's this approach called causal inference that's really got legs, and we should start to look at this. And so we did, and we felt like it's really the answer to a lot of our woes looking at observational data. So causal inference is really a framework for thinking. It's not a particular statistical technique, but it's a way of looking at data from the perspective of a randomized trial. This is not always possible. Some research questions just don't lend themselves to a potential randomized trial. But also some cohorts are just not large enough to apply the statistics that are required and apply the exclusion criteria that would make the research, applicable to a potential randomized trial. So the two main things that causal inference relies on are big health data. You can't apply those techniques to a really small cohort. So you need sort of statewide or, large site data sets. And as I said, the framework for thinking within the context of a randomized trial. And I only realized when I was going through my slides earlier that that's a very Australian reference. I apologize. That's a lyrebird, which is an Australian native bird. And they are famous for their ability to mimic other bird calls. So I've got that there as a nod to mimicking a causal trial, but I apologize for the very Australian reference. So it's not lost on me that causal inference and a causal framework of thinking is really being championed right now by Miguel Hernan, who is a professor of epidemiology at the University of Harvard. And he established the Causal Lab in 2021 to really promote these techniques. So if there's anybody who's worked with him or been involved with any of his projects, I'm more than happy to receive feedback at the end of the presentation. So timing of birth is a question that a lot of patients ask about, and it's certainly something that we're interested in clinically. Planned birth in pregnancy, so planned timing of birth, is something that is certainly on the rise. And this is where our first foray, if you like, into causal inference started. So we looked at the data in Australia, and this is a graph of induction of labour in first-time mothers, and the dark blue line is Australia-wide. And as you can see, in 2004, almost 26% of first-time mothers were induced in labour. But by 2021, that number had risen to 45%. So this is a really common intervention. And we have benefited greatly from the findings of the ARRIVE trial, which was published in 2018. Sorry, Brenda. And this was a trial led by William Grobman, published in NEJM, which really is a landmark trial and changed obstetric practice in a lot of ways. So 6,000 low-risk nulliparous women were randomised to induction of labour at 39 weeks compared with expectant management. And they looked at adverse outcomes and the experiences of the women induced. So although there was, a borderline non-significant reduction in perinatal mortality and severe neonatal morbidity, there was no evidence of harm. But in addition to that, the findings showed a 16% reduced risk of emergency caesarean section associated with induction of labour. And this was really significant and something that patients were really interested in. The trial also indicated that women who were induced felt more in control of their labour and reported less pain associated with that feeling of control. And based on that, based on the findings of this study, ACOG updated their guidelines to state that it is reasonable for obstetricians and healthcare facilities to offer elective induction of labour to this patient group, so low-risk nulliparous women at 39 weeks. So we really had, by that stage, good reassurance about short-term safety. but it really left a number of questions open about the longer term implications for the offspring of patients being induced. Sorry, can we? Yeah. So, so the timing of birth was going to be something that was very difficult to follow up in the ARRIVE trial. And look, they may well be funded to do so, but in order to look at the offspring implications for children, they're going to need follow-up in, 6 to 8 years of that original cohort. And although there were 6,000, you would need big numbers of those children followed up in order to find any significant clinical differences. Sorry, I'm so sorry, Brenda. Just keep it moving and I'll just talk to the slides. So this is where we brought together 3 very large data sets. The Victorian perinatal data collection is routine birth data collected throughout Victoria on all births. The Australian Early Development Census is a measure of childhood development, a global assessment conducted by teachers in the first year of school. And the NACLAN is our national numeracy and literacy program. And by bringing these 3 data sets together, we had about 170,000 births linked with longer term childhood outcomes. For many of you, that might seem that that's not big data in US terms, but certainly in Australia, that's considered pretty big. And it's certainly adequate for us to look at this research question. So the issue with observational data so often is that patients with different exposures and that experience different outcomes are not the same. They're not randomly allocated, and that's so often been the issue with sort of drawing any kind of causal conclusion from observational data. So women who birth at 39 weeks, certainly in Australia, and I suspect the same is true in the US, are more likely to be older, they are more likely to be multiparous, and they're often more likely to be from higher socioeconomic position and more educated in their options and ability to ask for that elective intervention. So as a result, we need to do something to balance out those populations, especially if we're going to try and draw any causal conclusions. And our team have used inverse probability weighting, which is a statistical technique which assigns a score, if you like, to the 2 cohorts in your study based on their likelihood of experiencing a particular outcome. And it uses the characteristics of those cohorts to balance out that probability. And so they are evenly weighted, if you like. And by doing that, we're able to look at them sort of in the context of a randomized trial and come up with causal conclusions. This is just trying to demonstrate the balance that the statistical technique achieves. And as a result, we can sort of pose a causal question, if you like. So does the exposure of planned birth cause the outcome of poorer educational or developmental outcomes in childhood? So very busy slide, I apologise for that, but this is just to demonstrate that from that original cohort that we had of linked birth and childhood development data, we had to apply potential exclusion criteria, if you like, for the potential randomised trial that we'd conduct. And in this setting, we excluded women who'd obviously birthed before 39 weeks, but also those that had had placenta previa or abruption or a breech vaginal birth because they couldn't be randomised to expectant management. We also excluded spontaneous or augmented labours, and that was so that we were looking just at a planned birth group. This gave us still healthy numbers in both those groups. And we looked first at the Australian Early Development Census. So our primary outcome was developmental vulnerability in 2 or more of the domains. And you can see here they're very broad: social competence, emotional maturity, communication skills. and vulnerability was defined as scoring less than the 10th centile in 2 or more of those domains. And we found that interventions, so planned birth at 39 weeks, had no impact on the risk of developmental vulnerability, so an adjusted relative risk of 1.03 and a confidence interval that crossed 1. We then went on to look at the individual domains just to make sure that we hadn't missed any hidden developmental vulnerability, and we found that the results were the same, so non-significant across all domains: physical health and well-being, social competency, emotional maturity, language skills, and communication skills. And this paper was published in JAMA Pediatrics, and it caused quite a bit of consternation, I must say. We had to remove all of our causal language throughout the paper because, of course, it wasn't a randomized clinical trial. But we got some really valuable feedback from the peer review process, and it really allowed us to hone our understanding of how we needed to apply this framework, and certainly what the priorities were going to be for us going forward, particularly in terms of communicating our findings and the way that we'd apply a framework. So we were able with this part to say that there was no impact of planned birth at 39 weeks on those early developmental outcomes. But what about the longer term outcomes for children in school? So for this, we looked at the NAPLAN assessment, which I said, is the national assessment of literacy and numeracy. It's again conducted across 5 domains. It's conducted Australia-wide every 2 years from the age of 7, and it's our only national assessment, if you like, of educational achievement in primary and secondary school. Sorry, Brenda. Thank you. So for this, we applied much more stringent exclusion criteria. So we'd really learned from our first experience, and we realised that there was quite a bit of critique about the exclusion criteria we'd applied in the first study, and the fact that we still had potentially included women who couldn't be hypothetically randomised to expectant management beyond 39 weeks. So we excluded a much larger number of patients, so women who conceived via IVF, and that's because in Australia, those women are recommended induction at 39 weeks. Similarly, women who had identified intrauterine growth restriction of their baby because they would be recommended induction earlier and not really allowed to be managed expectantly after 39 weeks, and a whole other lot of indications that we felt meant that women wouldn't be able to be hypothetically randomised to expectant management. Because this is an assessment that's conducted every year, unlike the AEDC, which is only every 3 years, we had a much larger cohort. So this was comparing birth at 39 weeks in 49,000 women compared with expectant management in 106,000 women. And so for the NAPLAN educational achievement, we were looking at Z-score, so standard deviations from the mean, collectively across all those 5 domains. So really wanting to highlight those children that were not meeting sort of the required minimum standard for educational achievement. And this was looking at specifically NAPLAN in grade 3, so the age of 7 to 8. And we, sorry, that's going backwards. And we found, again, no difference in educational outcome at the age of 7. So this was looking at an adjusted risk difference. So no difference with the null value of 0 for a risk difference being crossed here. So from that, we looked at the individual domains of numeracy and literacy. Again, similar to the other analysis, we were able to demonstrate that there were no hidden vulnerabilities, if you like, among children that were induced electively at 39 weeks. And so we felt pretty confident after both of these studies that we were able to conclude that the developmental and educational outcomes for children following elective sort of planned birth at 39 weeks were very similar and not impacted by bringing birth forward to 39 weeks. And this was a really exciting series of studies that's been included in a number of guidelines going forward, and it certainly contributed to shared patient decision making, and we hope that we can continue to contribute to that space. This is actually the other presentation that I'd sent earlier, but I'm happy to speak to the slides, especially if there's possibly a few CREI trainees here. So another project that we had worked on early was looking at IVF conception and educational outcomes following IVF. This was one of our earlier forays again into causal inference and really required a lot of close thinking, if you like, about the exposure groups and the ability to conduct a pseudo-randomized trial. So we know that IVF children children conceived via IVF are at increased risk of a number of adverse perinatal outcomes. These women are at increased risk during their pregnancy of diabetes, hypertension, the risk of stillbirth at term is increased. But what we really didn't understand a number of years ago, which is sort of extraordinary when you think about the number of children that are conceived via IVF, is what are the early sort of developmental outcomes for these children? What are the social and emotional outcomes, and are they different, or is it simply, not an issue? And what are the later educational outcomes for these children? So for this data set, we had 600,000 Victorian births. Brenda, I'll get you to just cycle through this quite quickly, if that's okay. And we were able to link with a really unique IVF data set in Victoria. So for the first time, we were able to access all IVF data across the state for our study period, 2005 to 2018. And the reason that that's difficult in Victoria, and I suspect it's probably similar in the US, is because that data is privately held. So it's not, the IVF data doesn't go into public registries that researchers can access. But after many approvals and a number of years of patience, we were able to access that data set, and it's proven to be a real wealth of information for us. So again, we looked at the same outcomes, so the Australian Early Development Census and the NAPLAN educational data. So this slide is just demonstrating that women who undergo IVF are often a very different patient group to those that are spontaneously conceived. So for starters, they have the condition of subfertility, and that often sets them apart in many ways. They tend to be older, but they also tend to be from higher socioeconomic position. They're more likely to be more highly educated and from more professional employment. So as you can see, the characteristics of these groups are very different, and that requires a lot of balancing and thinking about how that plays out in a statistical model. So for this paper, again, we used causal methods. So a randomized trial in real life would not be feasible to look at longer term outcomes. You could never feasibly randomize a group of women to conception via IVF versus not. And the main reason for that is that women requiring IVF to conceive couldn't ever be randomized to a spontaneous conception group. So this was the perfect setting really to use causal inference and look at these methods using observational data. So we set up sort of randomized comparison groups, if you like. And as I explained earlier, we use statistical modelling to weight the exposure groups for the differences in their characteristics. And here we looked at an average treatment effect. So comparing hypothetically everyone exposed compared with everybody not exposed. And we were able to demonstrate that although there were differences in the proportion of children that were deemed to be developmentally vulnerable, so 14% compared with 10% in the IVF group for the AEDC, so that's the early development group, the differences were nulled, if you like, once we controlled for those confounding factors. And looking at the final model, there was no difference in, so the risk difference, there was no difference in risk of developmental vulnerability in the AEDC between IVF and spontaneously conceived children. And again, non-significant risk ratio. And the same for NAPLAN. So that's the educational outcomes at primary school age. And we were able to see that the predicted mean, so of developmental or educational vulnerability, was no longer any different once we'd weighted for those demographic characteristics. And the mean difference with the confidence interval crossing that null value was no longer significant. So this was hugely reassuring and hadn't really been conducted at this scale before. So there's been a number of, that's okay, Brenda, yep. There's been a number of projects that have been conducted looking at this question, but not in very vast numbers. And certainly the comparison groups have proven to be really difficult. So this paper was published in PLOS Medicine. Again, we had a lot of kickback, if you like, about the use of causal language. So we really had to remove a lot of our causal inferences, but we were certainly able to talk about the way that we'd set up a pseudo-randomized trial. And again, we gained a great deal from our peer review feedback on this process. Despite the consternation with the scientific publication, this paper received a lot of media attention. Not really surprisingly, IVF is something that people are very interested in, and I guess it's an emotive kind of topic. This is one of our beautiful postdoc researchers, Rangi De Silva, and her gorgeous little boy, Amrith, and she became the face of this paper, which found its way to the front page of our local newspaper. And we had a series of interviews on radio and television. So it was one of those funny scenarios where we sort of, the publication process was pretty challenging for very good reason. And we really had to come up with a good compromise as to how we were going to present these results. But from a public perspective, this was a project that people were really interested in and felt very invested in the results. So it was a very interesting experience for us. So the traditional hierarchy of evidence, if you like, has systematic reviews, high quality systematic reviews at the very top with randomized trials snugly below, and that's certainly considered the gold standard of clinical evidence. But I guess we would propose that there's, you know, a different hierarchy in some ways, and that causal inference and causal methods in the right setting with the right research question has the opportunity to fit snugly between randomized trials. This is just demonstrating the the fact that correlation doesn't necessarily is not necessarily equivalent to causation. So you may look at this graph and think that margarine consumption causes divorce, but of course that's not the case. And it depends on the research question that you're asking and the setting in which it's being asked and the data that's being used to answer the question. So this is the hierarchy that we would propose with causal inference and causal methods in that gap. And yeah, we think that it definitely has a place in research going forward. So our big emphasis moving forward is pharmacoepidemiology. So, you know, prescribed medications in pregnancy. There are so many currently being used that we just do not understand the implications for often the mum, but also the offspring in the future. So developmental outcomes, educational outcomes, and certainly health outcomes for the babies as well. So we, as I've sort of demonstrated through the other studies, we're looking at primary investigation in our local statewide data set. But I guess an important thing for us in terms of proving or, you know, really ensuring our findings are as robust as possible is validation. And we're looking to validate a number of our projects using a Scottish national data set, which might seem a little bit random, but certainly Scotland has a treasure trove of routine birth data that's able to be linked with a vast array of other demographic data sets. And that data is able to be accessed by external researchers with the appropriate approvals and applications. And the next slide just demonstrates the interplay between those data sets and the fact that it's very similar in different jurisdictions around the world. So provided you've got the ability to perform high quality linkage between observational data sets, some of the data that we have access to in different countries around the world is just really extraordinary and holds a huge wealth of information and wealth of opportunity, really. And I think COVID demonstrated that really thoroughly, because the cost of research is inordinate in a lot of settings. Randomized trials, whilst definitely the gold standard in a lot of contexts, really can be incredibly expensive. But we have all this data at our fingertips, and there's no reason why we shouldn't be able to access it and be able to use it so much more effectively than we currently are in a lot of ways. And just finally, I'm sure many of you are really aware of the role of consumers in our research. Certainly our team are increasingly aware that although as clinicians we look after patients every day and we feel like we know what patients want to know, it's very different to having consumers contributing meaningfully to your research planning and the process of research. So we're really motivated to set up an infrastructure to involve consumers in our next tranche of projects going forward, certainly in the setting of prescribed medications in pregnancy and the outcomes for their offspring that they're most interested in. And this is just to end and say that whilst we all wish that we had a crystal ball, that we could look into the future and reassure patients about their outcomes and most importantly, the outcomes for their children often. We don't have that yet. But I think we are approaching a state where we're not prepared to accept the current status quo in terms of what we don't understand about the long-term implications of pregnancy exposures in many ways. And we really hope that our work starts to contribute towards being able to predict the future and reassure patients about the future and their offspring future much more accurately. And that's all from me. And I would just like to finish by thanking our pretty extensive team across a number of institutions, all of whom have been instrumental in these projects from different perspectives and different levels of research. So thank you very much, and thank you for the opportunity to present this work.
Anthea, spectacular, and thank you so much. Really interesting, both of course the findings and the method. I think of myself as relatively well read, but I really did not kind of know about this as like a whole different way of answering research questions, the ones that are really hard to answer. I think we've seen a lot more with pharmacoepidemiology here as well. There are just a lot of unanswered questions.
Yeah.
It's really exciting. So I would love for people to either unmute and just holler out their questions. Don't even need to necessarily raise hands. Certainly anything that is in the chat, I will take a peek at as well. But Anthea, I was just thinking to start, well, first of all, of course, the IVF stuff. We actually took our IVF REI didactics for today and put both our fellows and faculty on because it was such an interesting topic. So I'm very glad you did not, that we had your own slide set and we got the IVF.
That was lucky.
I mean, one thing we found as well is like almost anything that you publish related to IVF or the outcomes of our children, it really does matter to, consumers, to people. And so, just your thoughts on, it's a lot of responsibility. When it goes into the media, you lose control of it. This is kind of an aside, but is that something that was concerning to your group? Did you?
Oh, very much so. Very much so. I think you're absolutely right. And it is one of those really emotive topics. I didn't sort of draw attention to it, but it wasn't lost on us that the headline for that paper was exactly the same. So that's what they called the article. So there was no nuance. There was no sort of sense of, this is, this was years in the making. There was just that immediate, click sort of headline, like just reassurance, blanket statement sort of. So we were really aware of that. And certainly in a number of the radio interviews that we did, there was just an agenda happening that was very difficult for us to sort of control. I think it was a really good learning experience for both myself and my PhD student, Amber, who led that work, because we really had to quickly learn to take control of the narrative a little bit whilst those interviews were happening, because people come to, fertility discussions, particularly with all sorts of, background, emotion and experience. And that was really tricky. But I think your comment was absolutely true, that really highlighted to us the importance of consumer involvement and making sure that from the very beginning, we're hearing from the patients affected, not just clinicians working in this space, about the kind of outcomes that they're interested in as well. And I think that's something that we're particularly interested in going forward. We've got these sort of global assessments of outcome, but actually what patients want to know about, the things they really care about when they think about their future children and what they're going to be able to do or not, is really significant. Yeah.
Well, and this is just a little bit of an aside, but we do have a lot of trainees on that call as well. Don't hesitate to get media training from your institutions, because what's fascinating,
Yes.
especially a topic like this, you can give a really thoughtful interview and then all of a sudden you look at the quote and you're like, did I even say that? That was, so it is, it's important. And actually it's great you got such good media attention for something that was basically reassuring. I think we find here, and I don't know if the Australian media is different from US, but if it's bad news, I mean, just, you will hear no nuance in the article. IVF causes X, and then something bad, and the next thing you know, the media is really taken off with it. And they're so interesting. And I was also wondering, I mean, you are very fortunate. I'm sure we have a lot of big databases here, but it seems like certain countries do a much better job about having these, standardized testing that then researchers access, standardized developmental screenings that researchers can access. We often think of the Nordic countries, with a lot of jealousy, because we have such a mishmash system here. Is that a real benefit?
Oh, look, it definitely is. I think the quality and the accessibility of data in Australia is improving. So it's certainly, historically, it certainly hasn't been the treasure trove that it sort of is becoming. But I think there's been this widespread recognition that we do have a lot of these data sets that are routinely collected, and you know, previously they haven't sort of been linkable, or there's been no way of getting these data sets to talk to each other. I mean, it's kind of wild when you think about AI in other, you know, applications and settings, and the fact that we're still sort of trying to clunkily link these things, you know, that have existed for a long period of time. We were one of the first research groups in our state of Victoria to link maternal and child outcome data sets. So it's not something that's been done a huge number of times, and it did cause a whole lot of confusion for the very, you know, hardworking people that were sort of helping to link the data sets, because that concept of maternal pregnancy data being linked to future childhood outcomes and getting those maternal child pairs correct was not straightforward, but certainly not unattainable. And I think we've now shown that it can be done. And with our next tranche of work with the medication sort of based data, we've got a whole bunch more data sets that are being linked. And yeah, it's an incredibly wealthy data set, if you like. But you're right, the Nordic countries really are the global standard. There's no doubt about it. And I think the main reason for that is the foresight that they had in terms of wanting to be able to link that data. So having unique identifiers that speak to each other across different data sets, it's, you know, it is incomparable in a lot of ways.
But I mean, but when trade-off is, and again, you know, there's, in Australia, we think of being less diverse maybe than the United States, but you guys still have a lot of diversity compared to some of the Nordic
and increasingly
countries.
so.
Yeah, you really do. Whereas some of the Nordic countries, you know, our concern is it is such a homogeneous population. No, it's really exciting work, and I think great for a lot of the kind of younger investigators here to realize how much is at their fingertips. Because I mean, there's certainly, I think we, in our oncology space, I think the oncologists have been remarkably good about using databases, but a lot of us haven't. It was also really interesting when you said, you know, IVF data. There are a lot of us IVFers on this lecture. It's private here too. And it's a real problem. We do have a big CDC SART database. I think you have something equivalent in Australia.
Yes,
but there are a lot of our IVF programs that choose not to even put their information in SART. We have no really trackable data on things like gestational carriers and egg donors and sperm donors. And there's, you know, a lot of questions that will go unanswered unless there's kind of more leadership from the top and allowing access to some of this. But
look, I think that's true here as well. We just were very fortunate that it was the right timing. The PhD student leading that work, Amber, is an IVF specialist, and that was incredibly helpful. But yeah, look, it remains a bit of a smoky space, and I'm not sure what it will look like going forward as to whether we'll have access to that data again in the future.
I mean, there's no doubt consumers want it, and that probably will hopefully survive the opening up of all that data. I can't believe it's already 1:02, so we need to let you go, but cannot thank you enough. Fascinating, excellent lecture, and I think we've all learned a lot. And please,
great, thank you so
back
much.
into bed and have a nice. I hope you can sleep late.
I will try and do that.
Don't
actually,
have a 7 a.m. lab meeting Australia time.
No. I'm just going to do a quick shout out to Professor Sue Walker as well, who's on the call and just remarkably happens to be in London at the time, so was able to make the time difference work.
Wonderful. No, thank you. Really,
thank you so much.
Wonderful.
Thank you, Dr. Lindquist. This was great. Thank you, Dr.
Thank you. Really appreciate it.